Hi everyone. In this video, we are going to study about postpartum period complications. It could include hemorrhage, maybe placenta is retained, uterine inversion, postpartum pyrexia, mastitis, which could be lactational or non-lactational, and then some mood alterations. What is puerperium? It is the 6 weeks period after pregnancy when the body is adjusting, and there are changes in pregnancy which are anatomical and physiological. So when these changes are being reversed, we call it puerperium, which is a 6-week period of adjustment after pregnancy. Starting with the hemorrhage. How much loss of blood is what we call as a hemorrhage? As a postpartum hemorrhage is more than 1000 milliliters, meaning 1 liter. So loss of more than 1000 milliliter of blood after cesarean delivery, and depending upon the delivery, if it's vaginal, more than 500 milliliters. So in vaginal, we don't expect too much of blood loss. So more than 500 milliliter of blood after vaginal delivery, or bleeding associated with signs symptoms of hypovolemia within 24 hours of birthing process, regardless of mode of delivery. So any sort of bleeding which might cause symptoms of hypovolemia within the first 24 hours of birthing process, then we call it as postpartum hemorrhage. Primary within the first 24-hour postpartum, secondary after 24 hours, but within the first 12 weeks. So we're gonna expect that within the first 3 months, if there's any other type of bleeding, and then we'll call it as secondary, but primary one is within the first 24 hours. Etiology, how many what are the reasons behind it, right? So we have these 4 T's, which are the differentials of early postpartum hemorrhage. There is late postpartum hemorrhage too, which we said that within 3 months we can expect this, but for the early one, we can expect there's a uterine atony. Uterus tone is not firm. Then about tissue, maybe some placenta is still retained in the cavity or there are clots. Then trauma, any laceration, inversion, and thrombin, coagulopathy, right? So tone, uterine atony is the most common cause of postpartum hemorrhage. 70 to 80% causes include uterine atony. Avoid with active management of third stage of labor with oxytocin administration, uterine massage, and umbilical cord traction for delivery of the placenta. So how can we avoid uterine atony? We can avoid it by actively managing the third stage of labor, in which the baby is already delivered and now we are expecting the placenta to be delivered, and that stage takes around 5 to 30 minutes, right? So we are expecting in that time we can go with uterine massage, we can go with either oxytocin administration, we can manage it actively and put light traction on the umbilical cord for delivery of the placenta and avoid the uterus to go into atony. And why does it happen? It happens due to overdistended uterus, like in polyhydramnios or multiple gestations, macrosomia, when the uterus is so much overdistended and after delivery it decompresses very quickly, the uterus goes into atony. Uterine muscular exhaustion, prolonged or rapid labor, grand multiparity, oxytocin use, and under general anesthetic. So if the uterine muscle, the myometrium in it, after so much contractions, if it goes into exhaustion, then it can lead towards uterine atony. Uterine distortion, maybe there were fibroids which led to uterine distortion, and then intraamniotic infection, fever, or prolonged rupture of membrane. So if they had rupture of membrane more than 18 hours and they also had fever, so might be there's some intraamniotic infection going on, which can lead to uterine atony. Bladder distension, preventing uterine contraction. So bladder distension is also a cause behind uterine atony. If the bladder is too much distended, it prevents uterine contraction. And thus so tone is basically built up by the contractions, right? The tone is the musculature tone. So if there is not enough space to contract because of the bladder distension, then that leads to atony too. After atony, we'll need tissue, retained placental product, membranes, cotyledid, or succensurate lobe. retain blood clots in an atonic uterus. So if the uterus, so this includes both. The uterus turned out to be atonic, and we had retained blood clots. And then that tissue would lead to blood postpartum hemorrhage. And then gestational trophoblastic neoplasia. So if there was GTD, gestational trophoblastic disease, there was hydatiform mole, and then after that it turned out to be, it proliferated to be a neoplasia, or by any chance we cleared it out, we tried doing the dilatation and curettage, but there were still some remnants left behind which turned out to be neoplasia. Then that tissue can also cause postpartum hemorrhage. And then abnormal placentation, example placenta accreta. So it is implanted within the myometrium. So when that gets off, it is for sure gonna lead towards hemorrhage. So postpartum hemorrhage. Trauma, laceration, vagina, cervix, or uterus, episiotomy, hematoma. It could be vaginal, vulvar, or retroperitoneal, uterine rupture, and uterine inversion. So, any sort of trauma can lead to postpartum hemorrhage. Thrombin, coagulopathy, pre existing or acquired. So, most of the coagulopathies are identified prior to delivery. Low platelets increases risk. So, prior to delivery, we almost have a know how about the coagulopathies, but they can turn out to be even more dangerous during the postpartum period. It includes hemophilia, DIC, ITP, TTP, and von Willebrand disease. And DIC is basically the most common complication if we have placental abruption. So just remember the association between placental abruption and DIC also. Therapeutic anticoagulation. So that's if we are giving the patient anticoagulation, that therapeutic anticoagulation can also lead to coagulopathy and then bleeding. So that's why we don't really want them to be on anticoagulants. Investigation, how do we investigate about the postpartum hemorrhage? We just assess the degree of blood loss and then shock by clinical exam. Explore the uterus and lower genital tract for evidence of atony, retained tissue, or trauma. May be helpful to observe red top tube of blood. No clot in 7 to 10 minutes indicate coagulation problem. So first of all, we're just going to go for how much blood loss was there, and then if the patient is in shock, if they are too much hypotensive and tachycardic, and then just explore what's going on. So explore any of these causes, explore if there was any trauma, any tissue remaining tissue, or any changes in the tone of uterus. And for the tone, here's the medical therapy. And for the tone, we start with the bimanual massage first. I'll get to it. But before that, there was this thing that you just observe red top tube of blood. If there was no clotting, it means there was anticoagulation going on. That is the coagulation problem. Then that's a whole different sort of management. How do we manage them? ABCs are the important, because most of the patients are hemodynamically unstable because they are losing about a liter in cesarean deliveries and half a liter in vaginal delivery, and turning to hypovolemia within the first 24 hours. So we're just calling for help. We are administering 2 large bore IVs, run crystalloids wide open, sending over CBC coagulation profile, fibrinogen, cross and type packed RBCs, just because we might have to use them, we might have to administer them. Treat the underlying cause, Foley catheter to empty bladder, and monitor urine output. So we'll get to know what's the underlying cause, and then we are also going to go for Foley catheter to empty the bladder, just so if the patient was under anesthesia and they are not able to empty the bladder, or they are not able to move and empty the bladder distension might lead towards more and more uterine atony, because it's not letting the uterus to contract to get back towards its small size. So we have to administer put Foley catheter to empty the bladder, and we have to also monitor urine output. Why? Because we just don't want the patient to go very hypovolemic, so we are also going to monitor the urine output. Okay, so how can we manage atony? So I have a quick chart over here. That first we're going to go with bimanual massage, and then the first line thing which we have is oxytocin. Oxytocin would help getting the uterus back to contractions, and then back to can help uterus acquire back its tone. Then we're going to go for tranexamic acid, carboprest, stromatherine, methyl ergonovine, misoprostol. These are all, I wouldn't even say second line, third line. And then intrauterine balloon tamponade can help. We just insert a balloon and inflate it, and then that can help the uterine wall to the musculature to get back its tone. And then the last resort would be surgery. Okay, oxytocin 10 international units IM is preferred in low risk vaginal deliveries. Oxytocin IV infusion is an acceptable alternative. Oxytocin 5 to 10 international units IV bolus can be used after vaginal birth but not with elective cesarean delivery. So, what we are going to learn is oxytocin 5 to 10 international units IV bolus can be used after vaginal birth but not with elective cesarean delivery. We're not talking about the cesarean delivery. We also have carbitoken, a long-acting oxytocin. It's almost the same. It is the same thing, but it's a little long-acting. 100 micrograms IV bolus over 1 minute for elective cesarean delivery, or 100 microgram IM for vaginal deliveries with one risk factor of PPH instead of continuous oxytocin infusion. So how does this help? We don't have to continuously infuse oxytocin. We use carbetoken, which helps, which acts as a long acting oxytocin, and then we don't really require continuous infusions. Then we have methyl ergonovine maleate, which is an ergotamine. It can be given as IV bolus, but make sure you're not giving that in hypertensive patients, preeclamptic patients. Ergotamine, we're not going to give ergotamine. Then we have carboprost. So all of these were written over here together: carboprost, methyl ergotamine. We just have to be careful about their contraindications. So carboprost is basically a prostaglandin, and then it is contraindicated in cardiovascular, pulmonary, asthma, renal, and hepatic dysfunction. So we have to be careful if they have any heart problems, any asthma, renal, and hepatic dysfunction. So if not, then we can give, because they are major prostaglandin side effects. So that comes really to the end. And then misoprostol, 600 to 800 micrograms per oral or sublingual, which is faster, or we could also give per rectum or per vaginal. Side effect pyrexia if more than 600 micrograms, so the patient might have fever, but misoprostol is also an option. Tranexamic acid and antifibrinolytic 1 gram IV. So these are all the medical therapy options. We usually get sorted out just by oxytocin, so which is the first line option. And then we have these three options, and then tranexamic acid to control bleeding too. Local control for atony. For the local control, that's what we go with first. We don't really go directly to medical therapy. We go for the local control for atony, which is bimanual massage. Elevate the uterus and massage through patient's abdomen. So what we're going to do, elevate the uterus with one hand and then massage through the patient's abdomen from outside with the other hand. Uterine packing, mesh with antibiotic treatment, and we have to make sure that there are no infections getting in with during all these the actions we are taking with all these maneuvers we are doing. So we have to be sure that we are also administering antibiotic. Bacteria balloon for tamponade may slow hemorrhage enough to allow time for correction of coagulopathy or for preparation of an OR. So that is the tamponade which we put in the uterus, which restricts which controls the bleeding, but it comes just like third or fourth line treatment. Manual removal of retained placenta can also be used to treat PPH due to other causes. Surgical therapy, intractable PPH for atony. DNC, beware of vigorous scrapping, which can lead to Escherman syndrome, can also be used to treat PPH due to other causes. So we are going to go for DNC, embolization of the uterine artery or internal iliac artery by interventional radiologist, which is getting more and more obsolete these days. Then laparotomy too, we can go for bilateral ligation of that uterine artery, so that we can just cut off the supply from behind, and that would be happening if the postpartum hemorrhage is intractable. And hysterectomy is the last option with angiographic embolization. If post hysterectomy still bleeding persists, then we're gonna go for angiographic embolization. So that was our postpartum hemorrhage. Uterine atony is the most common cause of PPH, and it occurs pretty early. So that's how we go with it. We go for bimanual massage. We administer oxytocin. Then we have some other options too. Then we have balloon, and the intrauterine balloon tamponade, and then still, if no improvement, then we're going to go for surgery. And if it is intractable, we're going to go for surgery. um we just have to make sure, if we're going for surgery, if the patient is if they've completed their family or they still want future pregnancies, then we have to make sure, we have to avoid DNC, because that can lead to the adhesions in uterus, like Escherman syndrome, and embolization of uterine artery might lead to future infertility. And these surgeries usually are not pretty safe for reserving future fertilities. Next, we have retained placenta. Placenta undelivered after 30 minutes postpartum. So the third stage of labor is 5 to 30 minutes. And if it persists more than 30 minutes, placenta is undelivered, then we call it as retained placenta. Placenta is separated but not delivered, or abnormal placental implantation like accreta, increta, percreta. So it's like maybe on the os, maybe into the myometrium. So these are the various complications of placental implantation, and that can be a cause of retained placenta. What are the risk factors? If the patient has placenta previa, then we can expect. If they had prior cesarean delivery, or prior myomectomies by any chance, just because that would lead to a scar, and that scar would most likely lead towards placenta accreta or placenta previa, or maybe that scar has some retained placenta on it. And post pregnancy curettage, if they had post pregnancy curettage, prior in their prior pregnancies too, or in this pregnancy also, prior manual placental removal, that they had to manually remove placenta, and uterine infection. Infection can also lead to a retained placenta. Sorry, risk of postpartum hemorrhage and infection. So if the placenta would stay in there, there is a risk of postpartum hemorrhage and infection. Investigations, we're just going to explore the uterus, assess the degree of blood loss, and we're going to manage it with the same ABCs. Then IV bore, two large bore IV needles, and type and screen. Then we have Brandt maneuver. What we do is we put one hand on the suprapubic area, and we apply a pressure over there, and with the other hand we are putting firm traction on the umbilical cord, and we just have to put a little bit of pressure. It's not like we are pulling it out, we just putting firm traction, but we have to be sure that we are holding on the suprapubic area. We are holding, we are putting that much of pressure that we are holding the uterus in place. We don't want the uterus to invert and come out with the attached placenta. If it is excreta, and if it is on the fundus, it's going to take the uterus, whole of the uterus out. We don't want uterine inversion. That has many other complications too. We're going to read it in the next paragraph. So we don't want uterine inversion. That is why we have to apply suprapubic pressure, cephalad, by holding the uterus in place. Okay, with that we're going to give oxytocin if placenta. So first one is like a little bit of traction, then oxytocin 10 international units in 20 milliliter normal saline into umbilical vein. Manual removal if above fails. DNC if required, ultrasound guided if available. Cefazolin 2 gram IV if manual removal or DNC. So if we are removing the placenta manually, or we are doing dilatation and curettage, we would like to give antibiotics. So first of all, just some maneuver, then oxytocin just to produce a little bit of contraction so that it can go out. Then if still not, we're going to go for manual removal and DNC with antibiotics. Cefazolin 2 grams IV. Uterine inversion. We just read that if the retained placenta is being pulled, then that could lead towards inversion. What happens is inversion of the uterus through the cervix with or without vaginal introitus. So even if not in vagina, but it inverts towards the cervix. It inverts and goes through and through the cervix. It is often iatrogenic. Excess, maybe you put excess cord traction with a fundal placenta. So if this is a uterus, this is the cervix, here's the bladder and rectum, and here was the fundal placenta, and the cord is out, but you're putting some traction also, and you're trying to put like apply mild traction. But if there's excess cord traction with the fundal placenta, it would pull the uterus out of the vaginal introitus. Make sense? Excessive use of uterine tocolytics, more common in grand multiparous women because they have lax uterine ligaments. The uterus, which is attached to the pelvic and to the surroundings, they are now, there is laxity because of grand multiparity. So it is more common. The uterine inversion is more common in those cases. It can cause profound vasovagal response with bradycardia, vasodilation, and hypovolemic shock. Shock may be disproportionate to maternal blood loss. So there could be a scenario in which they're not going to explain you properly. They haven't looked into the cervix yet, but they would give you a scenario that maternal blood loss was not that much. It was within the normal limits. Say in vaginal delivery it was 200 ml. And then, but when you see the vitals, there's the blood pressure is around what, 90/50, and there is 120 heart rate, right? So shock may be disproportionate to the maternal blood loss. There wasn't enough blood loss. The shock doesn't really explain blood loss. So if there is shock and it is disproportionate to the maternal blood loss, there is profound bradycardia, vasodilation, and hypovolemic shock, then we could say that it might be because of the vasovagal response that happens in uterine inversion. How would you manage? It's urgent management, essential, call anesthesia, ABCs, initiate IV crystalloids. You can use tocolytic drug or nitroglycerin IV to relax the uterus and aid replacement. So first of all, you would want to relax that uterus, and then you're gonna aid the replacement. You have to replace it manually. So you just replace the uterus without removing the placenta. Remember, this is the key point over here. This is very important, that you have to replace the uterus without removing the placenta. You don't want to remove the placenta, that oh, now it's inverted already, uterus is outside, we can see the placenta directly implanted to the uterus, let's remove the placenta first and then we can put it back. No, you have to replace the uterus first, because that would lead to immense hemorrhage, like too much of a hemorrhage. So you have to replace the uterus first, and then you have to remove the placenta. Remove the placenta manually and withdraw slowly. You can also give IV oxytocin infusion only after the uterus is replaced inside, right? You're not going to give oxytocin. You don't want contractions when the uterus is outside. So when it's outside, first of all, you're going to go for tocolytic agents, so that so that it relaxes first, or you can also go for nitroglycerin so that it relaxes, then you put it back manually. After just reviewing it, so after the ABCs, after the trying to stabilize the patient hemodynamically quickly, initiating IV crystalloids, give a tocolytic drug, relax the uterus, and aid replacement. Right after that, replace the uterus, then remove the placenta manually, At that time, if you're removing placenta manually, you would want your uterus to be in tone. You would want your uterus to just let go of the placenta, because oxytocin would help it. So when the uterus is infused inside, you can use oxytocin for removing the placenta, or you could remove placenta and then use oxytocin, so that if there's any of the retained stuff, that can come out too. And then you have to re-explore the uterus again, re-explore if there's still anything left. May require general anesthetic with or without laparotomy, because there is vasovagal response which is profound. So you may want to put the patient in general anesthesia, put them into sleep. All right. Postpartum pyrexia. It is fever more than 38 on any two of the first 10 days postpartum, except the first day. So first day we do expect, right? So except the first day, um if we have any 2 days, any two of the first 10 days, if we have fever more than 38, then that is postpartum pyrexia. What causes it? Etiology: B5Ws. So first, breast, there might be engorgement, there might be mastitis, because baby's mouth is full of candida and whatnot, so staph aureus. So that might cause, during the breastfeeding, that might cause mastitis. And then all the 5 Ws, I would put womb to the top and then the rest. So womb is first with the breast, then the womb. Endometritis, that infection might cause postpartum pyrexia. Then talking about the rest: water, UTI, walking, DVT, thrombophlebitis. So DVT maybe postpartum. They're not walking that much. They're trying to rest more. DVT. Wound, episiotomy, CD site infection. That is very common. Wind, atelectasis, pneumonia. I'm sorry. So, etiology: endometritis, wound infection, check CD and episiotomy sites, mastitis, breast engorgement, UTI, atelectasis, pneumonia, DVT, or pelvic thrombophlebitis. How are you going to investigate it? You're just going to take detailed history, physical examination, just look at the sites first, try taking relevant cultures. For endometritis, blood and genital cultures. Serum lactic acid for early detection of sepsis. You want to rule out sepsis, so you're going to go for serum lactic acid. If we've just talked about endometritis, that we are going to take some blood and genital cultures. What is endometritis? It is the inflammation of the endometrium, of course, most commonly due to infection. How would you treat it? Of course, you're going to treat it with the antibiotics, right? What are the risk factors for endometritis? What would cause endometritis? Cesarean delivery, intrapartum chorioamnionitis, prolonged labor, prolonged rupture of membrane, and multiple vaginal examinations, operative vaginal delivery. So any of these things which are exposing the insides of the uterus, the endometrium, with some agents from outside. And in such cases, when there is rupture of membranes, when there is prolonged labor, the mucus plug is gone. Now there are chances for ascending the bacterial infections. So prolonged labor, prolonged rupture of membrane, multiple vaginal examinations, maybe operative vaginal delivery using forceps. They had chorioamnionitis when the baby was in their cesarean delivery. All of these could cause endometritis. How does it present? Fever more than 24 hours postpartum, chills, abdominal pain, uterine tenderness, foul smelling vaginal discharge, or lochia. That would be purulent mostly in cases when it presents. I've written more than 24 hours postpartum, because we are giving an exception of the first day. That could be normal too. right? Physiological. But if it is after that, then we are going to consider endometritis. They would have some abdominal pain, lower abdominal pain. Uterus would be tender on examination. Vaginal discharge would be foul smelling. The scenario would be saying that they're post term. They gave maybe vaginal birth 3 days ago, and now they're having some abdominal pain. They're also having fever, and uterus is tender. Vaginal discharge. Oh no, they don't really give you everything, but and then they would just give you something like what like during the labor they had to use some forceps to deliver the baby's head, and then nothing else. So that is a risk factor for endometritis, and that might have caused endometritis. So that is how they give the scenario. So how do you treat that infection? Based on the severity, oral antibiotics if they're well, but IV antibiotics if hospitalization is required. Clindamycin and gentamicin is the most common drugs, which covers pretty much everything. Oh yeah, so there was a little bit of treatment left, like in the general treatment. So it of course depends on the etiology. If there is antibiotics, we're gonna go for empiric. I mean, if there is infection, we're gonna go for empiric antibiotics. Adjust when sensitivity is available. For endometritis, as I just said, clindamycin and gentamicin. Instead of gentamicin, we can also give tobramycin. So Clindgent in endometritis. In mastitis, if the pyrexia is because of mastitis, we're going to go for cloxacillin or cephalexin. We're going to read it in the next table. And then wound infection, cephalexin, and frequent sitz baths for episiotomy site infection, that really helps. If there was DVT, then anticoagulants. Prophylaxis against post-cesarean delivery endometritis. Administer 2 to 4 grams IV based on BMI 30 minutes prior to skin incision. So this is a prophylaxis from the endometritis which happens in the cesarean delivery. What we do is, before doing the cesarean delivery, we give them 2 to 4 grams of IV cefazolin. This really helps avoiding endometritis for no reason. We just read antibiotics in at the top in somewhere. What were we reading about? Yeah, about the retained placenta if we are going invasive. If we are going for manual removal and DNC, we are going to give cefazolin 2 grams IV. Of course, whenever we're getting in something, whenever we're being invasive, we should be giving prophylactic therapy. So for wound infection, it is cephalexin again, and frequent sitz bath for recommend that for the episiotomy site infection. Okay, mastitis. It is of two types, lactational and non-lactational. What is it? It is the inflammation of the mammary glands. Must rule out inflammatory carcinoma as indicated. So make sure ruling out the red flags. Differentiate from memory duct ectasia. What happens is memory duct ectasia is the duct beneath the nipple gets clogged and dilated. There could be inflammation, there could be discharge, which could be thick, gray to green, and that often happens to post-menopausal women. But mastitis and lactational, we are talking about, of course, lactational women, but not non-lactational is not usually, we're not saying that it is in postpartum people. It can be in a non-postpartum too, but you have to make sure that you're differentiating from memory duct ectasia because it can present pretty much with the same condition. There would be erythema, and then there would be ductal inflammation, there would be nipple discharge, but that is often in the postmenopausal woman. Ectasia, as its name says, that the duct has dilated and it's exactly beneath the nipple, clogged and dilated. How do we rule out inflammatory carcinoma? We're just going to make sure um, mastitis is painful. So carcinomas are usually not. And then they have the masses, they have some nodules, some masses which do have spiculated border, irregular borders. Mastitis, nothing like that. And then they would have on mammography they would have indications towards carcinoma too. And then things like Paget disease, some nipple retraction, and those things, right? Lactational, non-lactational. Lactational, most common, then non-lactational, often 2 to 3 weeks postpartum. Staph aureus is the cause behind it. It is unilateral, localized pain, tenderness, and erythema. How are you gonna treat it? You're gonna treat it with heat or ice packs, and continued nursing and pumping. You don't want to stop. And that used to make me think that mm, isn't the baby gonna drink all the pus, but all the purulent material? But it's not the abscess from where the baby's having it, right? It is mastitis. It is just inflammation in there. You don't want to stop it, and you don't want to get it get it to dilate, right? So continue nursing, continue pumping even on the same side. Go for antibiotics, cloxacillin, dicloxacillin, cephalexin, erythromycin if penicillin allergic. If there is abscess, now there would be difference. If there is abscess, there would be a fluctuant mass. There would be purulent nipple discharge. That nipple discharge would be purulent. In mastitis, you didn't see any discharge. Fever, leukocytosis. We have to discontinue nursing in that case. Go with IV antibiotics, nafcillin, oxacillin, incision and drainage usually required. Right? So abscess would be different than mastitis. And you would feel a fluctuant mass. Non-lactational, which is periductal mastitis, most common. Mean age 32 years, may be sterile, may be infected with Staph aureus, smoking is a risk factor, may be associated with memory duct ectasia. So non-lactational can be associated with memory duct ectasia, which happens in the postmenopausal. And it is exactly subareolar pain, may have subareolar mass, may have discharge, may have nipple inversion. That is non-lactational mastitis. We go for broad spectrum antibiotics, we go for incision drainage, and we excise. The definitive measurement is excising that complete duct. If mass does in abscess, if mass does not resolve, fine needle aspiration to exclude cancer, and ultrasound to assess presence of abscess. Treatment includes antibiotics, aspiration, or incision and drainage. So we have to rule out cancer by fine needle aspiration. May develop memory duct fistula also. A minority of non-lactational abscess may occur peripherally in breast with no associated periductal mastitis. So what happens is the non-lactational ones, they occur in periphery of the breast. They're not really around the areola. In them, in the Staph aureus one, we usually give vancomycin, the non-lactational ones. Postpartum mood alterations. Three sorts. It could be blues, it could be depression, it could be psychosis. Blues are the earliest ones, 3 to 10 days. Depression could be somewhere between 6 months, but within 6 months postpartum, within 6 months childbirth. And psychosis could be like it could be somewhere within the first 2 weeks, and it can also last for months. Psychosis. In blues, it's just some normal hormonal changes which are just extending. They're trying the new moms are trying to adjust with the babies, and it is pretty common. It is self-limited. It usually resolves within 2 weeks. But how does it show? They're a little depressed, they have mood problems, tearfulness, fatigue, and the concentration is not pretty good, and insomnia, and they are very sensitive to criticism, they're anxious, irritable. That's postpartum blues. But depression, that is major depression. It is just like MDD, just like the the criteria which we have to fill out of these 11 things. It is completely that. It is major depression. It's not like just blues. Um, and there is a risk of recurrence of 50%. So make sure that if there is in the scenario they're telling you that they had postpartum depression in the previous pregnancy too, most likely they're going to have it again. What are the risk factors? They had personal or family history of depression, which includes the postpartum depression too. If their sister had um, postpartum depression, or you would say, oh, that was postpartum depression, that wasn't the major depressive disorder, so it might not be related. No, if even a family history of depression, which includes PPD, prenatal depression or anxiety, they were very stressful life situations, they have poor support system, they didn't want that pregnancy, the baby's not well, the baby's sick, baby turns out to have some abnormality. These are the risk factors. When are you gonna suspect it? Suspect if the blues last beyond 2 weeks. So the scenario would come to you like, so there's a girl who gave birth to a healthy baby 3 weeks ago, and now she has fatigue and she's feeling insomniac, but she mentioned that she is hopeful that when she could get some rest, she would feel better. So what is your next step? How are you gonna what are you gonna say that to her? So I was thinking that she's not hopeless. She thinks that she's gonna get better when she gets rest, right? But no, you have to pick the option in which you are trying to rule out depression. You have to rule out depression if the blues are lasting beyond 2 weeks. So in this case, if the blues last beyond 2 weeks, or if the symptoms in the first 2 weeks are severe. So the first 2 weeks were too severe that you didn't have to wait till the end of 2 weeks. You just directly go. There was extreme disinterest in the baby. They were suicidal, homicidal, or infanticidal. How do you assess it? You assess it with Edinburgh Postnatal Depression Scale. You give them antidepressants, you go for talk therapies, psychotherapy, supportive care, and then, if refractory, if still not working out, go for ECT, electroconvulsive therapy. And then postpartum depression, sorry, postpartum depression does interfere with bonding and attachment between the mother and baby, so it can have long term effects. Last is the postpartum psychosis. It's just psychotic episodes that is triggered by complex psychosocial stressors, hormonal changes that occurs following birth. So it is like in between, as early as within the first 2 weeks to till it can also take some months, but it is pretty rare. But if it has occurred once, then there are 50% chances of recurrence in the next pregnancy. Increased risk in individuals with the prior psychiatric illnesses like bipolar disorder, schizoaffective disorder, schizophrenia, or other psychotic illnesses, or personal family history of postpartum psychosis. Even family history of postpartum psychosis. How do you treat them? That is a psychiatric emergency. You just have to make sure that the baby is safe, because the baby is at risk of infanticide. You just typically hospitalize, give mood stabilizers and antipsychotics. So make sure that you're hospitalizing them. Make sure you're ruling out suicidal ideation. You're hospitalizing them and keeping them safe and the baby safe. Postpartum OCD is also a thing. There are chances of recurrence. New onset increases. Pregnancy to postpartum. What does that mean? Pregnancy to. So within pregnancy, they might have it. Or it could be a new onset too. So they're more and more preoccupied with Also, the scenario could be like they are more preoccupied with breast milk contamination or harming the baby, or they have compulsions that they are just showering and making the baby shower, or keeping the baby like wrapped up all the time, putting some sanitizers or whatnot. So that would not go towards psychosis. That would be OCD, because there are chances of having OCD too. So again, cognitive behavioral therapy, and we can also give SSRIs. By the way, SSRIs are safe in pregnancy too. So these were some postpartum complications. Then we have postpartum care. Postpartum office visit at 6 weeks. So at 6 weeks, you are going to expect the mommy to come back to you for the postpartum office visit. This is just a quick read, so I'm just going to do that. Care of mother, the 10 B's. Be careful, do not use douches or tampons for 4 to 6 weeks post delivery. Why? There are chances for TSS, toxic shock syndrome, by Staph aureus, by the tampons. There might be a scenario like that too, and you were there as. Be fit, encourage gradual increases in walking, Kegel exercises. So, we are not suggesting anyone to have bed rest unless there is an indication. Gradually start increase in walking, do Kegel exercise, get your pelvic floor strength back. Birth control, assess for use of contraceptives. They would be needing birth control. Breastfeeding, it is not as effective as other methods of birth control. Oh yeah, it's not, it's just 15%, I believe. For more detail about different lactational amenorrhea approved by WHO for up to 6 months if meets criteria. Amenorrhea, fully or nearly fully breasting. I'm sorry, amenorrhea, fully or nearly fully breastfeeding, no interval of more than 4 to 6 hours between breastfeeds, and less than 6 months postpartum. So this is what we call as lactational amenorrhea. It is approved by WHO, that we say that for up to 6 months there is lactational amenorrhea. They don't have period because they are lactating. They are breastfeeding. It is not as effective as other methods of birth control, but you can just let them know that if you're having amenorrhea, if you're like fully breastfeeding, that's it's not like you're supplementing it with the baby with the formula. No interval of more than 4 to 6 hours between breastfeeds, and there it is less than 6 months of postpartum. Then we call it as lactational amenorrhea. Bladder, assess for urinary incontinence, maintain high fluid intake. So you want to maintain high fluid intake, but you don't want to go for urinary incontinence, because there was say there was vaginal delivery, they had episiotomy, and then the pelvic floor muscles are weak. Now the urethra is hypermobile, there is stress incontinence, so you have to look for that too. Blood pressure, especially if gestational hypertension. Blood tests, CBC for anemia if had postpartum hemorrhage, TSH if subclinical hypothyroidism in pregnancy, 75-gram OGTT if GDM. So that's that. All the three things which I just said, all of them are MCQs. In the gestational diabetic mommies, you're gonna go for 75-gram OGTT. It could be anywhere between 6 weeks to 6 months. For the mommies who had subclinical hypothyroidism, not like clinical, not like having levothyroxine, but there was hypothyroidism, you're gonna assess them TSH. That pretty much hides TSH. The ones who had PPH, you can have a scenario. They explain everything. She had PPH in the first week, pretty much first week, and you treated them, and it went well. Now they're here for 6 weeks for postpartum visit, and what are you gonna do? Are you gonna do intimate partner violence? You're just gonna a quick checkup and do nothing, and all the mind-boggling options, you're gonna go for CBC because we are gonna rule out anemia because they had PPH. So that is how we're gonna go for TSH if they had subclinical hypothyroidism. We're gonna go for 75-gram OGDT fasting if they had GDM. Make sure that you're looking for blues, bowel, fluids and high fiber foods, bulk laxatives for make sure you're trying to avoid hemorrhoids or perineal tenderness. Pain medications, donut cushions, sits baths, ice compressors. So, you know, um, constipation because there was progesterone throughout the pregnancy and now it's not there. So there would be physiological changes going on. So make sure more and more fluids, and you're also giving high fiber foods, and the patient is having bulk laxatives if they need it for hemorrhoids, of course, and constipation. Breast and pelvic exam. Watch for staphylococcal or streptococcal mastitis or abscesses, with or without pap smear at 6 weeks if due for screening. So if they were due for screening and during pregnancy for some reason, like maybe cervical insufficiency, you didn't really go for it, go for pap smear at 6 weeks if due for screening. Staphylococcal or streptococcal mastitis, you have to be careful for that too. I was thinking of UWorld scenario regarding staphylococcal. I totally forgot. That was regarding mastitis. There was a scenario in which they breastfed a baby for like throughout the day, but the dad fed them pumped blood collected in the day, and the mom really rested for the night, and they that led to mastitis. That was because the milk was stagnant. Breasts were pretty engorged because of not being pumped or being fed to the baby. So that could also lead toward breast engorgement and all of this mastitis stuff. Okay, moving forward quickly, physiological changes postpartum. Uterus weight rapidly diminishes through catabolism. Cervix loses its elasticity and regains firmness. So uterus weight would rapidly diminish, and cervix will lose its elasticity. Should involute almost 1 centimeter below umbilicus per day in first 4 to 5 days. Reaches non-pregnant state in 4 to 6 weeks postpartum. So in 4 to 6 weeks postpartum, you're expecting the uterus to get back to the non-pregnant state and the cervix. So it takes around a month and a half. Ovulation resumes in 45 days after giving birth. Non-lactating women usually ovulate sooner than lactating women, but um, don't just rely on it. And if you're lactating, you're not using contraception because you could have a baby in like near future too. Lochia, normal vaginal discharge postpartum, uterine decidual tissue sloughing. So, vaginal discharge is normal, but you would see some bleeding because there would be Lucia rubra because the decidual tissue is sloughing off. Decreases and changes in color from red in the early Lucia rubra, presence of erythrocytes 3 to 4 days, pale Lucia serosa, white yellow Lucia alba, residual leukorrhea over 3 to 6 weeks. So for over 3 to 6 weeks, you're gonna have such discharge. Foul smelling lochia suggests endometritis. So that is a pathological state. Endometritis. Breastfeeding problems. Maybe there's inadequate milk. Go for domperidone. Breast engorgement. Give cold compresses. Manual expression pumping. Nipple pain. Clean milk off nipple after feeds. Moisturizer, topical steroid if needed. So moisturizers do help. Topical steroids. Mastitis, just treat promptly with decloxacillin. Inverted nipples makes feeding difficult. Maternal medications. So you just have to consult if you could continue giving on medications, which are right here, um, which are contraindicated in pregnancy. During breastfeeding. So these are some breastfeeding problems. Then we have, right here. Yeah. So these are contraindicated when breastfeeding: chloramphenicol, cyclophosphamide, sulfonamides, nitrofurantoin, tetracycline, lithium, phenindione, cryptine, antineoplastics, immunosuppressants, psychotropic drugs, because they can cross the barrier. You can take acetaminophen and NSAIDs, anticoagulants, antidepressants like SSRIs, anti-epileptics like phenytoin, carbamazepine, valproic acid, antihistamines, antimicrobials, penicillin and stuff if you're not allergic, of course, beta-adrenergic, propranolol, insulin, steroids, OCPs low dose. All the estrogen containing OCPs may decrease breast milk production, so we just recommend progestin only pills. Bladder dysfunction, pelvic floor prolapse can occur after vaginal delivery. So any of the organs, like maybe bladder, which we call as cystocele, maybe rectum, which we call as rectocele, maybe the uterus itself, which is providentia. So any of these things could prolapse after vaginal delivery. There could be stress or urge, urinary incontinence, increased risk with instrumental delivery or prolonged second stage. So if they had instrumental delivery, most probably they can cause such bladder dysfunction, or the second stage was prolonged. Conservative management for second stage is the one in which there is 10 centimeter dilation already, and now we're waiting to baby to deliver. Conservative management for stress and urge incontinence, pelvic floor retraining with Kegel exercises, pelvic physiotherapy, vaginal cones or passaries, and lifestyle modifications like limit fluid or caffeine intake, local vaginal estrogen in breastfeeding women to strengthen the vaginal mucosa, because during breastfeeding it is pretty much pseudo-menopausal, because there is suppression in the ovulation, and then there's not that much of estrogen, so there is an hypoestrogenic state that could lead to um um what do you say dry vaginal mucosa. So you would want to give local vaginal estrogen. Puerperal pains. So there are some after pains which are common in the first 3 days due to uterine contractions. You just encourage simple analgesia. You can give ice packs, sitz baths can be used on perineum if painful. Encourage regular analgesia and stool softener. So stool softener does help in puerperal pains. They are the first 3 days postpartum. That's it regarding postpartum. Thank you.